Hi, my name is Andrea Portocarrero. I'm one of the third year fellows, and we're going to start the presentation about IBD. See if this works. Okay, it's working. So we are going to touch on, I feel like probably some basic and practical aspects. We're just going to talk about the big differences between ulcerative colitis and Crohn's disease. And we're also going to talk about the basics of treatment. And as we go, we'll touch on what is the abdominal imaging that you usually use to even diagnose and follow up or evaluate a flare in these conditions, and also the endoscopic evaluation. We are also going to talk about a couple of things that residents should know when admitting a patient with a flare. And if we have time, we'll talk about some of the role of a primary care doctor, or what you usually do in the outpatient setting to monitor and prevent IBD. So we're going to go through the basic aspects. So here to the left, we have ulcerative colitis, and to the right, we have Crohn's disease. I think that it is important that we know, and this is very basic, that ulcerative colitis will almost always involve the rectum. Not always exclusively the rectum, but ulcerative colitis, it will be very, very rare, very unusual that does not involve the rectum. And the inflammation is active at the rectum and then it expands proximally, and usually in a continuous fashion. And it also will involve, as you see here, the left side of the colon. That would be the descending and sigmoid, approximately at a 30 to 40%. And then you can also have extensive disease, which is the one that expands beyond the splenic flexure. But that will be less likely, but it does happen. And it will be like around 20%. But if there's something that you should know, is that ulcerative colitis has to involve the rectum. So you don't, the number is not here, but 90% of the patients have rectal involvement. So that is important to know. For Crohn's disease, it's a little bit different. It usually involves the ileal and cecal area. So the ileocolonic involvement will be the predominant feature. It's very important to have that area evaluated when you are diagnosing, or you're trying to evaluate someone that you suspect that has Crohn's disease. So what I want you guys to know is that Crohn's disease affects the cecum and the ileum. So because of that, you suspect that you want to do a full colonoscopy, but you also want to intubate your terminal ileum to take a look at the mucosa and get some biopsies. And also do some other imaging for evaluation of the small bowel that you cannot do with a colonoscopy. In Crohn's disease also, you are going to have just a small bowel disease. It's not going to be as common, but it happens up to like 30 to 40% of the time. And less likely is going to happen as well that you just have Crohn's colitis and you don't have a small bowel involvement. And this is in around like a 20% of patients, this could happen. Patients often have perianal disease as well, but the isolated perianal disease is infrequent. But you do have perianal disease that comes along with the involvement of the colon or the small bowel. I'm just gonna click off the chat so I get to come look at the slides. Yeah. Okay. So yeah, the inflammation and the affection of the colon and the small bowel in Crohn's disease is going to be, as what you know, like in patchy areas and skip lesions, as you can see here in this graphic. So moving forward, ulcerative colitis. So both diseases are similar because they cause inflammation and they can both cause similar symptoms, But someone that has ulcerative colitis, since it most frequently affects the rectum and the distal colon, is going to present with rectal bleeding most frequently. This is one of the most frequent symptoms, world signs presentation. Also, diarrhea and mucus in the stool. And since you have inflammation of the rectum, you're going to frequently have urgency and tenesmus. So these questions are very important to ask in a patient where you suspect IBD. It's going to help you differentiate between both. Here in the bottom area, we can see a normal colon. Looks like the transverse colon. And here we can see pictures of endoscopy of abnormal mucosa. This first one would be like a mild colitis. You see basically erythema. The mucosa does not look normal. And then as it progresses, you can see ulcers that can be initially superficial. And they can also be deep, like in the last picture. You also see that the normal folds of the colon, you basically lose that, and it looks more tubular. So these are some typical pictures of a patient with ulcerative colitis. So we're going to talk a little bit more about ulcerative colitis first, and then we're going to talk about Crohn's. For ulcerative colitis, it is important that you know the extension of disease, because this is going to help you determine your treatment. This is useful during colonoscopy, and also because patients with ulcerative colitis that have more extensive disease are at higher risk for dysplasia, and those patients need to be evaluated for high-risk colon cancer surveillance. So when you have colitis or inflammation that involves the rectum only, so it will be from the anus up to 15 to 20 centimeters, you're going to call that proctitis, of course. It's involvement of the rectum. But when it goes beyond your rectum up to your descending colon, that's called left-sided colitis. And it just goes up to the splenic flexure, up to around 50 centimeters from the anus. But anything that goes beyond 50 centimeters or beyond your splenic flexure, which is an area that you can differentiate anatomically during colonoscopy, that's called extensive disease. This table may seem a little bit, there's like a lot of numbers and a lot of classifications, but this is the Mayo score that you use to classify ulcerative colitis. We sometimes use it. There is mucosal endoscopic subscore that we do use when we see inflammation, but it's not very practical. Sometimes people use it, but this is used a lot for research, of course, and for all the trials. But what is important from here is to assess that they are going to ask about stool frequency, about the presence of rectal bleeding, the frequency and the characteristics of the stool. And then there's a score based on the colonoscopy, and there's also a score based on what the physician thinks is like, the severity of the disease. I think that from here, what is important to know is that anything from 6 to 12 is moderate to severe, and anything from 3 to 5 is mild. Usually when we read the literature about ulcerative colitis, they differentiate not between mild, moderate, and severe, but usually it's between the differentiation is between mild and moderate, and then moderate to severe. Because sometimes this may change, and it's not very strict, and it's very it can change really from time to time. So what is important to know is that most patients with ulcerative colitis are going to have mild disease at presentation, and we may not see them because most of these patients are treated in the outpatient setting. But there is a percentage of patients, there's a group of patients that are going to have moderate and severe disease, and some of them, not often, but they are going to present with something that is called acute severe ulcerative colitis. That is a term that you use for hospitalized patients that basically have, well, they are inpatient and they have more than 6 bloody bowel movements, and they have one marker of systemic toxicity. So we're going to talk a little bit about that as well. When we talk about Crohn's disease, you guys, we were just talking about ulcerative colitis, how frequent it is to present with rectal bleeding, mucus and stool, and tenesmus and urgency. Well, Crohn's disease can also present with those symptoms, but those are not the most frequent. It usually presents with abdominal pain. And if you have ileocecal involvement, your pain is going to be in your right lower quadrant. Patients also have persistent diarrhea. I mean, it could be intermittent, and you may really not think of Crohn's because it can be on and off, and this patient may be having the symptoms for years and no one knows. Because also has very non-specific symptoms as weight loss and fatigue. But it's important to know all of this and to ask, because these are red flags that in any patient will make you want to think about performing an endoscopic evaluation. So the most common symptoms in Crohn's disease are abdominal pain, persistent diarrhea, weight loss, fatigue, and also some patients present with perianal disease. Here in the bottom, we can see the terminal ileum, which you can assess during colonoscopy. When you get to the cecum, you get into the ileocecal valve. You can intubate in that area and take a look at the ileum, the terminal ileum. And well, this is absolutely necessary when you are evaluating a patient with Crohn's disease, because even if the mucosa looks normal, you need to take biopsies from that area. So this is a terminal ileum with an ulcer, as you can see here. And then these other pictures are basically of very inflamed mucosa. You can see like a cobblestone pattern here in the second picture, and then you can see in the last two pictures basically inflammation and ulcers that seem a little bit more deeper than the ulcers from ulcerative colitis. Since their patients can have a lot of inflammation in the colon, then as the mucosa heals, they could cause strictures, especially in the setting of Crohn's disease, because the ulcers are a little bit deeper, and the way it heals, with all the fibrosis of the tissue, it frequently causes strictures, not only in the colon, but also in the small bowel. Okay. So, any questions so far? Pick up the pace. Okay. Okay. The evaluation for Crohn's disease, well, as we were just saying, it is important that we do a colonoscopy and we take a look at the terminal ileum. It is important to evaluate with dedicated small bowel imaging, and you can use CTE or an MRE. Basically, it's a CT enterography and MR enterography. So this is necessary, and you need to do this in every patient where you suspect Crohn's disease. EGD is not always indicated, only if the patient has symptoms of vomiting, dyspepsia, or other upper GI symptoms, but it's not something that you do routinely. And also you can assess with capsule endoscopy, because with capsule endoscopy, you can take a look at some areas where you're not going to reach with colonoscopy. So like here in this pictures on the bottom, we can see these are some imagings from capsule endoscopies. We can see ulceration of the mucosa in all of them. Ulceration of the mucosa here, this ulcer looks a little bit more deep. And then you can see here basically inflammation, edema, erythema. What marker of, okay, Pune is asking, what marker of systemic toxicity do we check? We're going to talk about it, but like for example, with these patients with ulcerative colitis that meet inpatient criteria, and they are called acute severe colitis. It's just like heart rate more than 90, fever, hemoglobin less than 10.5, ESR more than 30, basically those things. And also you can complete your evaluation with fecal calprotectin as well. And we'll talk about it in a little bit. This is classification for Crohn's disease. Again, I want you to take a look here in this area where you see behavior. Crohn's disease can be non-stricturing, non-penetrating. Basically, you have inflammation, but you do not tend to cause strictures as a result of the healing of the inflammation. And then penetrating disease basically means that, as you know, the fistulas can happen. So a patient that has stricturing and penetrating disease, they have more severe disease, and you want to be more aggressive with the treatment from the beginning of the diagnosis, from the time of diagnosis. So it is important to know that patients with Crohn's can have non-stricturing, non-penetrating, they can have stricturing or penetrating disease. What are the complications of Crohn's disease? Well, you have fistulas. The fistulas are a result of transmural inflammation, and there is penetration into the mucosa as it gets inflamed, and it just goes through either another area of the small bowel, the bladder, the vagina, the rectum, and all of these different types of fistulas that you can have, like in the picture up here. Another complication of Crohn's disease is obstruction, which is the result of strictures. And these strictures can be inflammatory and non-inflammatory. What I mean by this is a patient with Crohn's disease that has had a stricture for a really long time may already have an area that is not going to reverse with just treatment and might need surgery, either just resection of that area to stop causing, to resolve the obstruction. And often we could also dilate areas endoscopically. But a patient could also have an inflammatory obstruction, which, there's an area of the small bowel that has a lot of edema and inflammation, so it causes obstruction. So if you start this patient on the adequate treatment, like steroids or an anti-TNF, that obstruction could resolve, and you may not need surgery for that. And also abscesses and phlegmons, and a lot of these complications for patients with Crohn's disease are managed by surgery. So I don't think that we usually see them in our practice when we are admitting, because these complications are most of the time surgical, and surgery is very involved in this. Talking about the imaging for Crohn's disease, we mentioned a little bit of this here. In the upper area, we have a CT enterography that I think what is the main thing to see here is, for example, in this image on the bottom right, you can see this is the area of the terminal ileum. There is inflammation of the mucosa, and you can see that you cannot really see the lumen. There is a stricture, and there is distal dilation. So the CT enterography and MR enterography are very helpful to evaluate for this, because there's no really other way that you are going to be able to tell. So in general, they're both very useful. Sometimes maybe a CT enterography might be more accessible for a patient that is admitted to the ED, but in a long term, probably an MRE will be better, because you're going to limit the exposure to ionizing radiation on a patient. So if you have to choose and you want to evaluate this and you have time, then you can probably get an MRE. But both are similar in sensitivity and specificity. Here, for example, in the bottom, you can see a little fistula. So here's an area of the small bowel with a lot of inflammation, and the lumen is also narrowed. And you can see here this little white area. This is basically a communication between two areas of small bowel. And here the same, inflammation of the mucosa, luminal narrowing. We're going to talk about basics of treatment. So, okay, so far any feedback so far? Okay. All right, so basics of treatment. We have 4 big categories of drugs for treatment of IBD. So these are 5-ASA, basically the mesalamine products. We have steroids that we usually use for to induce when a patient has a flare, to induce remission, not for maintenance. Immunomodulators and biologics. These are the different categories, big categories of drugs. So for Crohn's disease, the use of 5-ASA is controversial and is not recommended by the guidelines, but sometimes people do it because it's an anti-inflammatory anyway. But in general, we say that Crohn's disease, 5-ASA drugs are not indicated. But for UC, you can use 4 of them. And before you start treatment, it's important that you make an assessment of the extension and severity of disease to guide your treatment, because there's really not a step up or step down approach. If the patient has severe disease, of course, you're going to start with biologics, and it is recommended to start with aggressive treatment from the beginning. For the treatment of ulcerative colitis, I think that it's very important that we know what are our options in regards to 5-ASA. I feel like as a resident, I did not really know much of this, honestly, and the 5-ASAs is really the mainstay of therapy for ulcerative colitis, especially because ulcerative colitis is most commonly mild to moderate, and you can treat and induce remission and keep the patients on maintenance with 5-ASA products. So it's very important that we know of them. So depending on what extension of disease you have, you can use a combination of oral 5-ASA products like oral mesalamine, and also there are different options as suppositories and enemas. And this can get really complex, but I think that what is important that residents know is that you can use 5-ASA for induction maintenance, and a combination of both oral and rectal 5-ASA is superior to just monotherapy. So you can have a patient on daily, for example, the daily Aprisa, which is a mesalamine product, and at the same time have the patient use suppositories maybe 3 times a week. What is important for 5-ASA is to monitor for renal disease. Here, this is a chart with the different types of mesalamine products that are available. I think that it is important from here that you know that in general, they recommend to use mesalamine once daily because the patients have much more adherence with that. There are other products that are recommended to use up to 4 times a day, so patients do not really like that. But just I put these slides for you to be familiar with the names. Like Aprisa is one of the mesalamines. There's also another that is called ASUC, Liala as well, and then you have Canasa and Rowasa. Canasa is a suppository that you can use for ulcerative proctitis, and then Rowasa is an enema that is going to reach beyond the rectum into the sigmoid area. So you could potentially use that as well in combination with your oral therapy for a patient that has ulcerative proctal sigmoiditis. Going forward with the treatment, as far as steroids, the steroids that you use for ulcerative colitis and Crohn's are not only, a regular prednisone or prednisone oral. There are other formulations of steroids, especially the budesonide products, that you can use orally and also rectal. And because it has a high first pass metabolism, then you really don't get all of the bad side effects from steroids, and they're very useful and for induction of remission. And I would say that it's just important to know that you have an alternative up to prednisone, and that you can use budesonide oral and also rectal. So you should use these products when usually you have a patient with ulcerative colitis that does not respond to 5-ASAs. Then you can potentially start a rectal budesonide or an oral budesonide. Immunomodulators.
Brendan has a question actually. So when a person comes to the hospital with a flare, when and how much steroids can we give?
Okay, so let's go forward to that part. Let's see. And I'll come back to talk about the immunomodulators. So inpatient management. Again, this is not the most common presentation, but this will happen in up to 15% of patients. And these patients are going to require hospitalization for severe disease. These are the features that predict severe aggressive disease and ulcerative colitis. Basically, when you're young, when you have really bad ulcers, deep ulcers, when you have extraintestinal manifestations, when you really need corticosteroids even multiple times from the beginning of your diagnosis, and when you have elevated inflammatory markers. So this is the acute severe ulcerative colitis that I was talking to you about. That this definition is basically more than 6 blood bowel movements a day with a marker of systemic toxicity. And then going forward, I feel like you probably are familiar with the initial evaluation that you have to get your basic lab work. It is very important that you rule out C. diff. And once you already rule out C. diff, then you can start this patient on steroids. So the recommended steroid, according to the AGA, is a dose of 40 to 60 milligrams of methylprednisolone IV that you can use for 3 to 5 days. It is not recommended over 7 days because it has not been shown to be effective, and it can be detrimental. And by your 3rd or 4th day, you should, make an assessment as if this patient is really responding to your course of steroids. Because if they are not, then that's when you want to consider consulting colorectal surgery. If a patient comes with a severe ulcerative colitis, and even though you're starting steroids, and at this point, of course, GI is going to be involved, they may want to try infliximab because the anti-TNFs are also help you during a flare. But if the patient is really not responding at that time, it's very, very important that you have surgery on board because surgery can be curative for these patients with ulcerative colitis. And, just waiting a week is not really gonna help the patient in any way. And it's gonna lead to much, much more complications, even in the post-surgical state. So going back to Brandon's question, I think was the dose of steroids, right? So the recommended dose by the AGA is 40 to 60 milligrams of methylprednisolone per day. 40 to 60 milligrams per day. Okay. Awesome. So I feel like when a patient comes with ulcerative colitis and you're suspecting a flare, often these patients are going to present with rectal bleeding. And it is very, very important that you do start DVT prophylaxis with heparin. Even though the patient has some degree of rectal bleeding, unless it's really severe and massive, you're gonna hold the heparin. But these patients are at high risk for DVTs and venous thromboembolism. So it's very important that you do pharmacologic DVT prophylaxis. Also, there's no reason to put the patients on PO, if you're not planning on a procedure. So nutrition and continuing PO is very important as well. Other thing that is important to know is that antibiotics are not routinely recommended unless your patient really has a fever, or you do suspect an infection, or the patient has peritoneal signs that might make you think that might have like a phlegmon or an abscess. So that's the only time where you would use an antibiotic. But if your patient just comes with what sounds like what it is, a UC flare, you really do not need to start him on any antibiotics. And then you should avoid opioids or antimotility agents, anticholinergics, NSAIDs. And then if the patient is on like mesalamine outpatient is coming with a flare, really you don't need to continue that. So you can just hold those medications. And then, like I was saying, like you're in the middle of the night, you have this patient that is coming with rectal bleeding. You want to get your CRP, ESR. If possible, you can get a fecal calprotectin because that's gonna help. And if this patient has had previous fecal coat protectants, are going to help you also, to compare with the previous labs. You can also get a stool culture, basically for someone else. The stool culture panel covers for all the bacteria that cause bloody diarrhea. And then as far as if you want to prep your patient for the following day for a colonoscopy. So if your patient has ulcerative colitis, you really don't need to prep a patient overnight. Because most likely the patient is going to have just a flexible sigmoidoscopy, and for that you're just going to need a tap of water enema like half an hour before the procedure. And the answer is just don't worry about prepping your patient. You can put him NPO past midnight. The following day, GI is going to determine if we do a flexible sigmoidoscopy to assess severity and basically do biopsies to rule out CMV. Once you rule out C. diff, there's no there's no reason to just start steroids overnight. If your patient is, relatively stable, like a floor patient, you can still wait until the next morning once your C. diff is back to start this patient on IV steroids. But if your patient is in the ICU and there's concern for like toxic megacolon and other bad complications, then that's a different story. And you may want to start your patient. You may want to give him like a dose of steroids. So yeah, I think those are the important things to know when you're admitting your patient. Let's see what else.
This is Ram Prasad. A few things to add is when you said the IV steroids, it should be mentioned as divided doses, not one dose of 60 milligrams. It's 3 divided doses.
Okay.
Total is 60 milligrams, but divided dose. And cutoff is 3 days, not 3 to 5 days. 3 days, you start worrying about the patient. Heparin is a good point. Because heparin also has anti-inflammatory effects, so it's also helpful. Many studies have been done on it. The other clues are if the CRP is over 60, and in particular is over 80, almost 90% chance that they will not do well, so you have to be aggressive. And you keep saying calprotectin, people need to know if it's less than 50, we know it's not inflammatory. If it's less than 250 in IBD, we don't worry about it. If it's more than 2,000, we're really worried about it. So that's about what I wanted to say on that.
Thank you, Dr. Prasad. So any other questions about the inpatient management? We are going to see more often probably patients with ulcerative colitis admitted to the medicine floor because the patients that have flares of Crohn's disease, they're usually seen by surgery because they present with like a partial small bowel obstruction. They may also come to us to medicine, but a patient with Crohn's disease, their complications are different. So you can have a small bowel obstruction, then, the supportive care that you already know. You can start a patient on steroids and then eventually just surgery if the patient is not responding to medical therapy. If the patient has peritonitis, then you're going to need antibiotics. And if your patient have abscess as well, antibiotics or a percutaneous or a surgical drainage. But I feel like we less often see the patients with Crohn's disease on the regular medicine floor. I don't know if you guys agree with that. I'm going to go back to the treatment and especially the, I just want to mention the immunomodulators and biologics. So for ulcerative colitis, you can use azathioprine and methotrexate has no role. So you're basically going to use only azathioprine. And I feel like in general, it is important to know that for IBD and for a patient that is on an immunomodulator, on a biologic, in general, I don't know if they may be asking this in the wards, but it's been shown that the combination therapy of an anti-TNF and an immunomodulator is better than just an immunomodulator or an anti-TNF alone. So I think that's something to know about the treatment of severe UC and Crohn's disease. And I put this slide just for you, for the residents to be familiar on what are the biologics that are available. So as far as anti-TNF, we have infliximab. The commercial name is Remicade, and this is an infusion. We have adalimumab or Humira, which it is an injection, and of course, a lot of patients like it because they can just use it at home. An anti-integrin is Entyvio, vedolizumab, and the other one that we use is Stelara or ustekinumab. That is an anti-interleukin 12 and 23. There are other newer drugs, and one of them is this JAK inhibitor, which is not a biologic, but it's a DMARD that is usually used for like other rheumatologic conditions. The name is tofacitinib or Xeljanz. So this is for you to kind of have an idea of what is available. Any questions so far? This is making sense. Okay, perfect. And for Crohn's disease, the immunomodulators that you have available are both azathioprine and methotrexate, and you can use also these immunomodulators you can use as monotherapy, but they're better. They can also be used in combination with anti-TNFs. If you're going to use azathioprine, you need to check for this CPMT genotype before starting your treatment, and if you're using methotrexate, it's important that you follow for hepatotoxicity and bone marrow suppression. Yeah, I think that will be everything. So I think we can start with some questions.
Can you talk about I think we always learn about the step up, step down kind of theories. Can you tell us about like which one's in favor now? And
so in general, I think that there's really no step up or step down therapy, like for example in COPD or asthma. You just make the assessment of the severity of the condition of the patient, and based on that, you start your therapy. Like a patient that comes with moderate to severe ulcerative colitis or Crohn's, or penetrating stricture in Crohn's, you do want to be very aggressive from the beginning and start with anti-TNFs or a combination or an anti-TNF with an immunomodulator. And once your patient has had remission, then you usually keep your patient on the same medication, an anti-TNF, for example, because these drugs are not only for flares, but are also for maintenance. So you don't necessarily need to step down from that therapy. You can be on that long-term, and they are very safe. So there's really not a lot of step down from that. And then if you have a patient that has ulcerative colitis, and it seems like it's maybe mild or moderate, and you start with, for example, a 5-ASA, which is the basic treatment for ulcerative colitis. If your patient is not responding to that, you may kind of like quote unquote step up or basically try steroids for the flare to achieve remission. But once your patient has achieved remission again, you may increase your dose of 5-ASA or use a combination of oral and rectal, either as a suppository or an enema. But if your patient is really not responding to that and is needing steroids, I'm not entirely sure how many times a year, then you want to consider like quote unquote stepping up or trying a biologic. Dr. Rampersad, do you want to comment anything about that question?
Looks like Brenda had a question as well.
So Brendan's question is, can you reiterate the importance of testing for C. diff in these patients?
Yes, it's very important to test for C. diff. It's very important to rule out C. diff for every patient with either UC or Crohn's disease that comes with a flare. Yes, you want to do that. And again, you can wait until that test is back and that's negative for you to consider starting steroids. You don't need to necessarily rush overnight starting someone on steroids or prepping them overnight. So
Andrea, that's a good question, because C. diff in IBD is not related to antibiotics. So it's important to know that people with inflammatory bowel disease, particularly ulcerative colitis, we're not talking about Crohn's, have flare without any antibiotics or anything else. We're not exactly sure why they get it, but it may be related to medication or otherwise, or it's more cellular kind of stuff. They also has high incidence of recurrence. So some of them have suggested, the IBD guys have suggested recently, to continue treatment of vancomycin for 3 weeks, and they saw that they had less of a recurrence. I think the chemotherapy docs are doing it already, I believe, that they're extending the vancomycin. The other third thing is the flare. When the flare occurs, then the question comes up whether you should continue treatment with for inflammatory bowel disease with biologics, steroids, and the rest of the stuff. Among these, there is no real data for us to go by. And if patients really doing okay on C. diff, we don't see a problem continuing the medication. In particular, biologics seem okay. And the better the bowel, the better the recovery. In other words, the inflammatory bowel disease cannot be ignored and just treat the C. diff. So you need to continue to treat them, because we find that they don't respond to our treatments, including biologics, if you don't treat the vancomycin, treat the C. diff with vancomycin. Flagyl has no role whatsoever anymore in treating C. diff under any circumstance.
sounds good. Thank you, Dr. Ramprasad. I just wanted to add something that we often see in clinic. We many times have a patient that comes with more frequent diarrhea, abdominal pain, not necessarily bloody diarrhea, but that make us think if this is a flare or not. So there is a lot of IBD and IBS both happening at the same time. So it is very important, of course, your history and physical, to really identify if your patient could be having just IBS and not IBD. Because patient can have more frequent diarrhea, more frequent bowel movements, diarrhea, abdominal pain, cramps, and a lot of those symptoms can make you think that your patient may be having, like, for example, a Crohn's flare, and that might not be the case. So in that case, and that happens often in the outpatient setting, but I've seen it happening also in the inpatient setting. So it's very important that you just ask the patient all the appropriate questions, and ask them if this feels like a flare, and they will often tell you if it does or if it doesn't. And I feel like that's when your fecal calprotectin and your inflammatory markers and all of your stool studies are important to rule out other things before like committing this patient to escalating the therapy to something from, like, 5-ASA to a biologic. And we often, after we do this workup in the outpatient setting, we bring them to actually do a colonoscopy and see what's the inflammation, if it's real, and take biopsies, even if the mucosa is normal. Okay. I want to also talk about this IBD checklist for monitoring and prevention. Your patients with IBD are going to be at risk for osteoporosis. So this is something that we do in our clinics, and I feel like the primary care doctor as well is going to be involved in this, because these are things that primary care doctors also do. So you do want to check for vitamin D at least once in your patients. And of course, if they are deficient, you want to give supplementation. And then here, there's a chart, and I can provide this for the residents as well to know, it goes into the specifics on when to do bone density assessment. Like if you have been using steroids for more than 3 months, or you've been used steroids in the last year, and like different specifications of when to do a bone density assessment. But bone health is very important in the patients with IBD. Also, cancer prevention. The colorectal cancer surveillance for patients with IBD is usually done after 8 years of diagnosis, and they're going to ask you this on the boards. And after the 8th year, then you do want to start your colonoscopies every 1 to 2 years. And then they usually recommend chromal endoscopy, where you basically use a dye to try to do targeted biopsies to take a look at the areas that may be at higher risk for dysplasia, and of course biopsy them. But if your patient has also, besides IBD like US with PSC, you do want to start the colorectal cancer screening at diagnosis. And besides the colon cancer screening, it's also important that your patients have cervical cancer evaluation with annual Pap smears, and as well as skin cancer assessment by a dermatologist. So we're often referring our patients to get these assessments as well in our clinics. And here's a list of vaccines